I want to make sure we're all on the same page when it comes to malaria vaccines. And I think you can see my slides now, right? Okay. So although malaria is preventable and curable, and there's been great progress made in the last decades with malaria, malaria continues to be a primary cause of morbidity and mortality in children. This figure is from the World Malaria Report in 2024. And in gold, you see the estimated number of malaria deaths globally, and in blue, the estimated malaria deaths in the African region. And what you can see is that after some marked reductions in deaths through 2015, progress stalled. And despite ongoing efforts to reduce malaria, we've really reached a plateau. In 2023, there were an estimated 263 million malaria cases and 597,000 deaths, and the vast majority of these are in Africa. Tragically, there were over 432,000 child deaths in Africa in 2023. Malaria remains a primary cause of pediatric hospitalizations and death in many countries where malaria is endemic, and it continues to take a major toll on economies, on communities, and of course on families. I just want to show you what severe malaria looks like. This young child came to a hospital in Western Kenya where I worked. This is a typical presentation in an area of high transmission. It's often young children, or almost always young children who come into these hospitals. Under 5 years of age, they're the most susceptible because it takes time to build up the acquired immunity, and children have to survive these first episodes to be able to build up that immunity. They come in floppy or unconscious. You can see the intercostal contractions because of the deep breathing as they blow off acidosis. This child is severely anemic, as you can see, because of the hemolysis that happens with malaria parasitemia. There's also bone marrow suppression. And even with hospital care, there is a high associated mortality, but most children don't make it to the hospital from rural settings when they develop malaria. You will need effective anti-malarial treatment and blood transfusions if you have severe malaria. And unfortunately, the time from first fever to death is very rapid. It can be as rapid as 24 to 48 hours. And so prevention is really key. So that brings us to our preventive therapies or options that we have for malaria, and we do have a number of them. We call them imperfect tools that are applied imperfectly because none are 100% effective and none are scaled up to 100% of children. So to prevent malaria in children, we have as a cornerstone the insecticide-treated nets that have been scaled up since the early 2000s. We have in rather select situations indoor residual spraying. We have chemoprevention, which is a treatment dose of anti-malarial drugs that's given at certain intervals, either in areas of highly seasonal transmission or perennial year-round transmission. And now we have 2 malaria vaccines. And that brings me to talk to you about the clinical development of the RTSS vaccine and the malaria vaccine implementation program. So the first vaccine was developed over about 40 years. It's recombinant protein derived from the circumsporozoite protein, or CSP, from the P. falciparum parasites, and a hepatitis B surface antigen particle. And this is formulated together with the adjuvant AS01. The target is the CSP that coats the sporozoite. The sporozoite is the first stage of the malaria parasite life cycle that the Anopheles mosquito injects into the human host before it makes it to the liver and then enters the bloodstream. The vaccine elicits an immune response to the sporozoite and potentially interferes with entry into the hepatic cell. And the intention is really to stop infection before the parasites mature and multiply in the liver and then are released into the bloodstream when first symptoms occur. There was a large phase 3 clinical trial of the RTSS vaccine with about 15,500 children at 11 sites in 7 African countries across Africa, across endemicities. And the results from that trial showed that in the first 12 months after vaccination, vaccine efficacy against clinical malaria, which is uncomplicated and severe malaria, was 51%, and against severe malaria was 45%. But vaccine efficacy waned, and by 48 months after vaccination for children who were randomized to receive 3 doses, vaccine efficacy against clinical malaria was 26%, and vaccine efficacy against severe malaria was lost. Among children who were in the 4-dose arm, clinical malaria was reduced by 39% over 48 months, and there was maintained efficacy against severe malaria, about 32% reduction. So what we saw was that with this efficacy and waning protection, a 4th dose increased vaccine efficacy and prolonged protection against both clinical and severe malaria. There were also 3 safety signals that were seen in this phase 3 trial. There was no known causal association. They were considered potential chance findings, and later they were found not to be causally associated with a vaccine. But these were important as we were considering pilot introductions. Now, with this level of efficacy, it was seen that there was high impact with the vaccine. And this figure shows the number of cases averted per 1,000 children vaccinated over 48 months for clinical malaria and severe malaria for children who received 3 doses with the red bars and 4 doses with the blue bars. And these are the clinical SILE traits lined up from lowest transmission to highest transmission, and then overall. And what we saw was that there was high impact with 3 or 4 doses, particularly in the areas of high transmission. With children who received 4 doses, the reduction in clinical malaria was over 6,500 cases per 1,000 children vaccinated over this period. Mathematical modeling estimated that 1 child life would be saved for every 200 children vaccinated, and 250,000 to 500,000 lives saved during 15 years when the vaccine was at scale. So in 2016, WHO, on advice from its 2 key advisory groups, the advisory group for vaccines called SAGE and for malaria called IMPACT, reviewed the data and recommended to WHO, who adopted the recommendation, that there be large pilot introductions of the RTSS vaccine. And these were meant to answer the key outstanding questions following that phase 3 trial. These included the feasibility of reaching children with this 4-dose schedule that seemed to be required, especially because that 4th dose was given around 2 years of age, when most children had completed their childhood immunization series. The second question was safety in the context of routine use, and this was because of those safety signals. So they wanted a rigorous evaluation of meningitis and cerebral malaria, which were the 2 safety signals that we're seeing. And then impact on mortality, including gender-specific mortality, because there was also an imbalance in mortality by gender seen in the phase 3 trial. And these results would inform a WHO policy recommendation on the use of RTSS vaccine in young children. So the groundwork was laid, and we needed to start the setup for these pilot evaluations. And there were important scientific, operational, and financial components to consider. First, there was a letter, a call for expressions of interest from WHO, and 10 countries said they wanted to participate in the MVIP, the Malaria Vaccine Implementation Program, and Ghana, Kenya, and Malawi were selected based on pre-specified criteria. Then the countries had to get regulatory approval for use of the vaccine in the pilot areas. the vaccine had to be obtained, and GSK donated 10 million doses of the vaccine for use in the pilots. But we also needed long-term access commitments so that we could be sure that if the vaccine was recommended for use, there would be vaccine available. We needed to secure a large amount of funding to support the pilots, which we were able to do through Gavi Global Funding Unitaid. There were 2 oversight bodies that were established and followed the pilots throughout, a Data Safety and Monitoring Board and a Program Advisory Group. And then we selected through RFPs evaluation partners with experience in both sentinel hospital surveillance and community level surveillance. The countries then selected the areas for the pilot implementation subnationally. Here you see the maps in Malawi, Ghana, and Kenya, and then randomized where the vaccine would be introduced, shown in green, and the areas that would initially serve as the comparator areas, shown in red. And then the vaccine would later roll out to those areas once it was recommended for use. The red dots show the sentinel hospitals, and throughout the area, community-based mortality was established. You can see that there was a large number of children who were targeted for vaccinations in these areas, anywhere from around 300 to 400,000 children per year. So it was really a large cluster randomized evaluation. The Ministries of Health then launched the vaccine in April and September 2019 as part of their routine childhood immunization programs. So they integrated the schedule into the other childhood vaccination schedules. They delivered the vaccine in the regular child immunization clinics by the regular immunizers. They incorporated the malaria vaccine into their reporting systems, engaged the community through their usual ways. The vaccine logistically is very similar to other vaccines, so that was quite straightforward. And the EPI program, the immunization program, and the malaria programs worked together for integrated messaging so that parents could be assured that they needed to continue other malaria interventions while they receive a vaccine and always seek diagnosis and care for fever. We were then able to use to look at vaccine uptake through the routine systems in the 3 pilot countries. And this shows the percentage of children in the target population who received pentavalent vaccine, which is typically taken up at very high coverage levels, and then the malaria vaccine with the first dose here in blue, the 3rd dose in orange, and the 4th dose in green. And this is combined across the 3 countries. And you can see there was really actually quite rapid and high uptake of the first dose with minimal dropout to the 3rd dose. And I'll just say that this was during the period of COVID, so there were disruptions, but you really see how the childhood immunization platform is resilient, and they were able to reach children through this routine system. The 4th dose was more difficult. The countries had a very hard time reaching children with the 4th dose at 2 years of age. Ghana did something innovative. They moved the 4th dose from 2 years of age to 18 months of age, where they already had success with 2nd year of life vaccines, giving other vaccines, meningitis and measles vaccine, at 18 months of age with insecticide-treated nets and high uptake. And immediately, the 4th dose of the malaria vaccine jumped up to the similar uptake as the other vaccines. So over the period of the MVIP, over these 46 months, we were able to evaluate the impact and the safety of the vaccine. And what we found was, first of all, the vaccine was confirmed to be safe with no signs of the safety signals that were seen in the trial. But we also saw high impact. There was a 13% vaccine attributable reduction in all-cause mortality as the vaccine was rolled out. And this is really quite remarkable if you think about a vaccine against a single disease. And it really shows the contribution of malaria to child deaths in these areas. There was a 22% reduction in hospitalized severe malaria, And all of this was measured on a population basis in children age eligible for vaccine during a period of scale up when on average 70% of children who received 3 vaccine doses and 40% who received the 4th dose. So high impact despite low uptake of the 4th dose, and maybe room for higher impact as uptake increases. There was also no reduction in ITN use, uptake of other vaccines, and no decrease in care seeking for fever, which was important. The vaccine distribution was equitable, as vaccines often are, and also extended the reach of preventive tools. So in these areas where 60 or 70% of children had slept under an ITN, with the vaccine introduced, we had over 50% of children receiving at least 1 dose of vaccine and sleeping under an ITN, but over 90% of children having one or the other. During the time of the pilots, some investigators from London School, Mali, and Burkina Faso looked at the profile of the vaccine and noted the high efficacy during the first 6 months or so after the vaccine was delivered, and then that waning profile and the ability to increase efficacy again with additional doses. And they thought about this area in Africa where malaria is highly seasonal, the Sahel area. This is where about half of child malaria deaths occur. But it's areas where there are extended dry periods and then 3 or 4 months of really intense malaria transmission. And they recognized that they could give the first 3 doses of the vaccine just before the high transmission season, and then annual doses again. And perhaps this would optimize the efficacy of the vaccine. And they found, in fact, that it did. By giving the vaccine this way over a period of 5 years, they saw a first of all, during the first 12 months, they saw a 72% reduction in clinical malaria by giving the vaccine this way, and over 5 years, a 58% reduction. And the impact against severe malaria was quite high, 67%, and against all-cause mortality was 45%. So this is an innovative strategy that WHO also supports for these areas of highly seasonal transmission, which countries can choose to use. When we look at our mix of interventions, which I mentioned in the beginning, we can see that really we get highest impact when we combine these interventions. And this is using data from different clinical trials. We know from the clinical trials of insecticide-treated nets that they can reduce malaria incidence and burden by about 45%. If we combine ITNs and RTSS, or seasonal malaria chemoprevention, in these areas of highly seasonal transmission, we can reduce by 75%. And if we combine malaria vaccine, seasonal malaria chemoprevention, and ITNs, all 3, malaria can be pushed down more than 90%, which is where we want to see malaria. So the first malaria vaccine was recommended in 2021. We were very fortunate to get a second malaria vaccine, R21 Matrix M, which is at least as efficacious as RTSS, approved for use in 2023. And when the first vaccine was recommended, Dr. Tedros, our Director General, said this long-awaited vaccine developed in Africa by African scientists is a breakthrough for science, child health, and malaria control. The vaccine is a gift to the world, but its value will be felt most in Africa because that's where malaria is greatest. And I'm now going to hand over to Eliane, who will talk about that rollout across Africa of the malaria vaccine. So thank you.
Thank you, Mary, for a fantastic talk. I'm now pleased to introduce Eliane Pellaux. Eliane is a technical officer for malaria vaccines she's the technical officer for malaria vaccines at the World Health Organization's Department of Immunization, Vaccines and Biologicals. And she contributed to implementation and evaluation of the first vaccine in Ghana, Kenya, and Malawi. And she also provides technical guidance and support to countries for the introduction, implementation, and monitoring of the vaccines. So Eliane, we're delighted to have you here. Thank you.
Thank you very much. I hope you can see my screen.
We can see it perfectly.
All right. So the WHO recommendation provided the scientific foundation and the guidance to countries to consider vaccine introduction. However, the majority of malaria endemic countries are low or lower middle income countries in Africa, for which the financial barrier to new vaccine introduction is typically very high. Since the year 2000, these countries are supported by Gavi, the Vaccine Alliance, to subsidize vaccine introduction. And you can see here over the last 20 years, new vaccines have been added to Gavi's support portfolio. Gavi has since inception helped 78 countries to vaccinate more than 1 billion children and saving 17 million lives. So a very strong track record. And there was huge relief when shortly after the WHO recommendation, the Gavi board approved malaria vaccine support, which meant that eligible countries could from now on apply to Gavi. Countries are required to co-finance a share of the vaccine cost. The lowest income countries pay 20 cents per dose. This vaccine support was estimated to be able to save between 40 and 80,000 young children's life every year, once scaled up in all moderate and high transmission areas. So a very important investment by Gavi. Demand for a malaria vaccine has been very high since the beginning from governments in endemic countries. In 2022, there were already expressions of interest from 25 countries. It was estimated that about 25 million children were born in areas of moderate and high transmission, so a huge demand. Approximately 80 to 100 million doses were expected to be needed. And unfortunately, at the time, we faced a severe supply constraint. Mary mentioned there was one vaccine product at the time, and it was expected that we would have about 18 million doses over the first 3 years of rollout. So a significant mismatch between demand and the expectations by countries and available supply. So WHO was tasked to help develop a framework to guide how the limited malaria vaccine supply should be allocated in a fair, transparent way. And this was at the time of COVID, so there was a lot of experience, and including, unfortunately, negative experience with distribution of vaccine and access. So it was really important to find a fair, transparent way to do this. What you see here is a summary of the final allocation framework. I would just like to highlight that the first priority principle for allocation was to allocate the vaccine to countries with areas of the greatest need. So where the malaria disease burden in children and the risk of dying from the disease are highest. So really focusing on these highest need areas within the country. This in practice then meant, so this is an example from one of the countries that applied the framework. Each country was asked to do a subnational stratification of its malaria burden and child mortality under 5, and identify the areas where the burden and the needs were greatest. And you can see here, Cameroon has a lot of these, what we call the category 1 areas in dark purple. So a lot of highest need areas. In the framework, there was also a cap on the number of total vaccine doses a country could get in the initial phase in order to be able to reach more countries rather than a smaller set of countries. So here, Cameroon, for example, decided to go for this subnational introduction in a subset of these greatest need areas. And this is very atypical in a way for a vaccine introduction. Normally, when a vaccine is recommended, it's typically introduced at national scale. So this was different for the malaria vaccine. As Mary mentioned, we started with 3 countries during the pilot phase from 2019 up to 23. And then after the pilot, with the recommendation for use and also the arrival of the second malaria vaccine, countries were really able to scale up. And we saw a massive scale up in 2024. By the end of the year, there were 17 countries. 3 of them had national introductions, reaching about 4 million children or targeting 4 million children per year. As you can see, most countries were forced to go for subnational introductions given the initial supply limitations. In 2025, so by as of today, we have cumulatively 22 countries. Some of these countries have been able to scale up, so go beyond the initially limited areas. And we now have a target population of about 10 million children per year. Among those countries that have so far been able to introduce subnationally, all of them would like to go higher, but there are some limitations. As you can see here on this little diagram, the scale at which countries operate at the moment are quite diverse. We have countries that cover 4% of children at risk, for example, in Nigeria. Other countries have been able to go to 80% or even 100%. The median is about 30%. So there's still a lot of children at risk and not protected by the vaccine. One of the limitations, and I will talk a bit more about that later, is a current financial constraints by Gavi, the main supporter. At the moment, countries can apply for support up to a maximum of 85% of the population living in areas of moderate and high transmission. So again, only a phased subnational coverage. I would like to talk about some of the programmatic opportunities of the malaria vaccine. Mary mentioned the uptake in Ghana, Kenya, Malawi, and this is with the new vaccination schedule for the malaria vaccine. The vaccine is recommended from the age of 5 months. You can see here a typical immunization schedule of a country in Africa with the different antigens on the left and the time points when these doses are given. Many vaccines are given in the first weeks of life. Then the malaria vaccine, many countries have opted for a schedule giving the first dose at 5 months, second dose at 6 months, third dose at 7 months, or close to that range. And then the 4th dose in the second year of life, often aligned with another already existing vaccination visit. And so now this in a way creates challenges because new vaccine visits need to be promoted, caregivers need to get used to that schedule, so do health workers. But it's also a big opportunity. For example, these new visits at 5 months provide an opportunity to catch up children that may have missed any of the infant vaccines. There is often a quite well-established vaccine visit at 9 months for the measles vaccine or meningococcal A vaccine. This visit then in some country coincides with the 3rd dose of malaria vaccines, but if not, again, it can be used to catch up children that were missed with the malaria vaccine. And then the same is true in the second year of life. At these visits, other health interventions can be given and are often foreseen in the country's program, but are not always provided as such. For example, vitamin A is given in many countries at 6 months, 18 months, 24 months. So again, the presence of the malaria vaccine can reinforce those touch points. There's also growth monitoring that should happen more regularly, deworming at 12 months. And then also distribution of bed nets. We've seen good examples where the availability of a bed net, for example, at the 18 months visit was another motivation to come for that visit. Then within the malaria control space, there are also now new opportunities to mutually reinforce immunization and malaria control through coordinated activities. And I would like to give 3 examples. Perennial malaria chemoprevention is recommended by WHO. So this is providing prevention doses to children, previously called IPTI. And the malaria vaccine new visits provide additional opportunities for adding additional PMC doses. And this is currently explored or done in a few countries. Then there is seasonal malaria chemoprevention, another very impactful recommended intervention where preventive treatment doses are given during the high transmission season, often through door-to-door distribution campaigns. And these door-to-door distribution campaigns are opportunities to check the vaccination card and the records to see whether a child has missed any vaccine dose. And this is not limited to malaria vaccine doses, but can include any vaccine doses. And starting from actually last year, but particularly this year with the start of the season, we see many countries actually using this opportunity to promote integration and promote vaccine uptake. As Mary mentioned, a strategic use of both vaccines is to provide the doses in a seasonal way. At the moment, all countries except from one have opted for an age-based vaccination schedule because it's more like all the other vaccines. It's easier to do. But we have one country, Mali, that has started with what we call a hybrid approach, so aiming to give the fourth and the fifth dose in a seasonal way. And then Guinea-Bissau is planning to do the same. And then finally, as I mentioned, bed distribution can be timed with vaccination visits, for example, at the 18-month visit, or distribution campaigns can be used to reinforce messages or check for vaccination status. And at WHO and with partners, we're trying to really promote this and support countries. I would like to talk about a few of the challenges we've seen in the countries that have introduced so far. Generally, uptake has been good and demand is high from the communities. We see a lot of excitement among health workers and among the communities, but a few countries have some challenges with retaining children for the completion of the full course. So we have high dropout between doses in some of the settings. And this has been attributed to different factors. There's some misunderstandings in some situations about the eligibility. The new schedule needs to be promoted and really advertised. Caregivers need to be reminded about the touch points. Some countries don't have a system or insufficient system to track defaulters. So it's difficult to get children back for subsequent doses. And then also we've seen already in the pilot implementation that there are some generic challenges providing vaccines in the second year of life when children are older. Sometimes it's due to logistical barriers or bringing in a child that is heavier and bigger, and there may be already other children, smaller children in the family. But there also can be some other access barriers. We have seen in the last couple of years some growing disinformation trends, not necessarily related to the malaria vaccine, but more generally to vaccination. So this, in some contexts, has been a challenge where really messaging and the integration of communities in vaccination efforts need to be strengthened. And then I would say the biggest challenge at the moment are funding gaps. Even though Gavi had a quite successful replenishment event recently, it's still facing a shortfall for its next strategic period. And this may force a reduction in the malaria vaccine support. There are also funding limitations at the country level, of course, and this limits the ability to address some of these immunization system or health system challenges. For example, what I mentioned about the lack of defaulter tracing systems. On the graphic, what I wanted to illustrate is the missed opportunities. Here shows in blue the children that received the measles vaccine at 9 months, and then in purple the malaria vaccine at 7 months. And as you can see, there's a mismatch of the size of the bars, which means that there are missed opportunities at the 9-month visit to get children back. And so there's still scope for improvement in some countries. And then, of course, there are also more general funding challenges now for malaria control, with reductions in support, including from a main donor, PMI. I'd like to finish by outlining a little bit the next steps. So there is a target by the Gavi Alliance, of which WHO is a partner, to enable vaccine implementation in 25 countries, at least by the end of this year. We are on track to achieve this. This would help protect 14 million children by the end of the year, and then hopefully 15 million children by the end of 2030. Key to this now is to continue the support for new introductions and scale up in the countries to reach additional areas of moderate and high transmission. Support countries to increase uptake, help address some of these dropout challenges, and also continue to pursue these opportunities for coordination and integration. There's also a big effort to document and share the lessons learned. There's a lot of learning happening right now in all these countries, so we try to promote sharing of that. And then finally, we continue the support for fundraising, both for Gavi and also the Global Fund, to really help close those gaps, and also advocate for vaccine price reductions by the manufacturers. And so this shows the first babies vaccinated in the 22 countries that have introduced so far. And this brings me to the end of my presentation. Thank you very much.
What a lovely finish on. Thank you, Eliane, for an inspiring talk. So lastly, we're going to move to Simon Draper. So Simon is Professor of Vaccinology and Translational Medicine at the University of Oxford. He's based in the Department of Pediatrics and the Kavli Institute for Nanoscience, and they focus on vaccine-induced immunity. So we're very much looking forward to your talk.
Great, thank you very much, and good afternoon, everyone. Thank you for the invitation, and it's a real pleasure to be here. So what I'd like to do in the next few minutes is give you a brief flavour of some of the exciting opportunities and scientific advances that are coming down the track with regard to next generation malaria vaccine strategies, and building on the success of what you've just been hearing about from Mary and Eliane. Before I do, I thought I'd spend just a brief moment reflecting on the sort of real scientific progress that underlied the two fantastic approved vaccines that we do have. It's important to remember that development of a malaria vaccine has been a real scientific challenge. We have a highly evolved multi-stage life cycle as the parasite shuttles between the human host and the mosquito vector, really complex immune evasion strategies, and high levels of antigenic diversity. So a real challenge for vaccine developers. Now, scientists have started to find, or have found, chinks in the parasite's armor, but even when we have found them, you might have to take my word for it, but you need really strong immune responses in order to stop this single-celled organism. So those chinks, or some chinks, have been found. One of them is on the sporozoite, which Mary described in her talk, a protein called CSP that overlays the surface of the sporozoite form. If you look at it down a microscope, it looks like a little eyelash swimming around. But the CSP protein has two domains at the end, and then in the middle are these runs of 4 amino acid repeats. The second half of the protein is what's in RTSS and R21. And we know that if you get really high levels of antibodies against those repeats in the middle, that you can protect. So how was this achieved with the current vaccines? Well, they're based on what we call virus-like particle technology. They use the hepatitis B surface antigen, so the Hep B vaccine many of us will have had. And on the surface, they arrayed the CSP. So with GSK, it's in a 1:4 ratio, shown there at the top with RTSS. And on the left with R21, made by my colleague Adrian Hill in Oxford, they achieved a 1-to-1 ratio, so a higher density of CSP. And those particles are given in really strong adjuvants called AS01 from GSK or Matrix M from Novavax. And when given in these regimens in young children that you've just heard described, you can get these very high levels of antibody response, and you can boost them back up after a year. But as Mary said, they do then decline over time. But it was that combination of virus-like particles and strong adjuvants that enabled those vaccines to succeed. Those vaccines do block infection at the liver by the sporozoite, but as Mary described, they do wane over time as those antibodies come down. And unfortunately, when a single sporozoite slips through that net at the liver and comes into the blood, then you're still at risk of clinical disease. So what are next generation vaccines aiming to achieve? Well, a number of schools have thought on this, but in essence, still aiming to achieve higher efficacy and improved duration of protection against disease in young children. We'd love to reduce the number of doses. We'd love to reduce the cost of goods. And there's discussion now in the field as well about using vaccines in older age groups to block transmission and also for use in local elimination strategies. Now, there's different approaches worldwide from lots of exciting groups doing research into how we might achieve this. But a very common goal at the moment within the field is to now bring in other components around that complex life cycle to give a multi-stage or multiple lines of defense by vaccination. And that's what I'm going to focus on for the remainder of this presentation. So there are a number of strategies you can take to do this. One is a so-called transmission blocking strategy, whereby you target proteins on the sexual or mosquito stages of the parasite. So we've identified, or the field has identified, some chinks in those armor, so to speak. And if you target antibodies against those proteins, they get taken up into the mosquito, into its midgut. They interfere with the sexual process and stop the parasite developing inside the mosquito. One of those lead candidates is known as PFS 230. It's on the surface of the sexual gametocyte. And in fact, just a few weeks ago in Science, a beautiful cryo-EM structure was published of that protein by Wei Hong Fan's group in Australia. So we now know what that looks like scientifically for the first time. But we've known for a while that these antibodies work. They are measured in what we call a membrane feeding assay. So you can take malaria parasites in blood, you can feed them to mosquitoes in the lab, and you can see if the antibodies interfere with parasite development. So this graph just shows you some example data from preclinical studies. And on the right, you can see in control mosquitoes, in this experiment, you get about 10 to 20 oocysts. Those are the malaria cysts forming inside the midgut. You can see some vaccine antibodies didn't work, but then a few examples here, such as PFS 230 or 25, where those antibodies have completely blocked 100% development of the parasite inside the mosquito. Now that work's been taken forward clinically, that the lead candidate developed by Sarah Healy's team and Patrick Duffy at the NIH. They published some exciting data just a few months ago at the start of this summer, where they tested a vaccine in Malian adults targeting that PFS 230 protein delivered in the AS01 adjuvant, again from GSK. These data in the adults showed that in terms of the antibodies, as you get more antibodies in those individuals, you saw higher transmission reducing activity, which they measured in those assays, as I just described to you. And over a 2-year follow-up period in those vaccinated adults, they showed that the proportion of mosquitoes that they could infect experimentally was reduced by about 75%. So some really fantastic proof of concept there in West African adults, in humans for the first time, and a really sort of exciting start to work on transmission blocking vaccines. The second approach that you can do is try to target the parasite in the blood, and that's what my own lab has worked on for many years now. So the blood stage parasite emerges from the liver, following a week-long incubation. This little video on the top right just shows you a blood stage merozoite coming in, attaching to a new red blood cell. It reorientates onto its nose, forms a tight junction and pulls itself in to the cell. So it's a very complex biology. But development of blood stage vaccines has been really hard. It's been a real struggle for a long time. There's a lot of genetic variation in that parasite. If you think back to sort of variants of concern for COVID, this is on a massive scale. And there's also a lot of biological redundancy. By that, we mean the parasite sort of has spare keys to the lock. So if you knock one out with an antibody, it's got a spare key. But a real breakthrough in this field was the identification of a protein called RH5 back in 2011. Our lab found it by doing vaccine research, and at the same time, Gavin Wright's lab in Cambridge in the UK identified it from a receptor ligand screened. But in short, this RH5 protein was exciting because it broke the mold. It was highly conserved, so not polymorphic, and it was essential. It's not redundant. There's no spare key to the lock. And 15 years later, nobody's found an exception to the rule. This RH5 protein must attach to its receptor called basogen on the red blood cell for malaria to get in. So blocking that interaction with antibodies has become the leading strategy. And that's what my own team have been working on. Similarly, we know what this interaction looks like. Matt Higgins' lab in Oxford reported this in 2015. RH5, shown there in yellow, docks into its receptor, shown in blue. And we've done a lot of work on human antibodies in the last few years, seeking to understand how they block that interaction to guide vaccine design. And this little cartoon on the right just shows you RH5 in the middle in grey, and those coloured blobs are human antibodies that we've isolated, and we can see where they bind, and we can understand how they interrupt the interaction with the receptor basogen, and we can use that information to inform our vaccine science. In terms of the vaccine, the lead candidate is called RH5.1. This is a protein vaccine we developed over 10 years ago in Oxford, targeting the RH5 molecule. We took that into clinical trials, first with AS01 adjuvant from GSK, and then switching to Matrix-M, working in partnership with Novavax. These trials have been led by Angela Minassian's team here in Oxford, but working with our partners Ali Alotu at the Ifakara Health Institute in Tanzania and Halidou Tinto in Noro in Burkina Faso. And to date, they've vaccinated over 360 individuals, adults and children. The vaccine's been well tolerated and there have been no safety concerns. In short, the most exciting result relates to efficacy. And earlier this year, we published our first proof of concept data on that. This was a phase 2b randomized controlled trial in young 5 to 17-month-old children in Burkina Faso, the same age group as was tested with RTSS and R21. And in terms of our primary endpoint, which was efficacy against clinical malaria over the malaria season, or the first 6 months, efficacy was significant at 55% against the same primary endpoint as used for the vaccines RTSS and R21. So we have been braced for zero. This was very pleasant to see for the first time ever a blood stage vaccine working on its own. What was also really interesting was then we looked ad hoc at higher levels of parasitemia. We saw even higher levels of efficacy of over 80%, suggesting this vaccine is dragging down parasitemia in the blood, as you would expect from a blood stage vaccine and from a preclinical model. So we're really interested in that observation and whether that would mean in a real world setting, whether this would help to prevent more severe forms of malaria disease. So we've now just been funded by EDCTP, a new consortium led by Angela Minassian in Oxford and Maglo Anatoma in Noro in Burkina Faso. And imminently, trials will be starting to look at that combination of R21 with the new blood stage vaccine RH5 and taking that forward as a multi-stage approach. So just to finish, in the last moment, I talked at the beginning about what next generation malaria vaccines are aiming to achieve. I talked about aiming for higher efficacy and improved duration, potentially reducing the number of doses. But all of these vaccines work through antibody and face that same challenge that I've outlined and Mary discussed, which is about high levels of antibody coming up and then waning over time. And of course, we want to keep children above that protective threshold for as long as possible. So how do you do that? Well, one option is to bend the curve. That's a really interesting immunological question, which I don't have time to talk about, but happy to do so in the questions if you're interested. The alternative is to try and lower the bar by getting a more functional or better quality antibody response. And I think this is where these multi-stage vaccines are potentially really exciting and whether they have the prospect to synergize. And what I mean by that is when you give the RTSS or R21 vaccine at the liver stage, you prevent infection into the liver and you reduce what is going to come out into the blood. And the question is, does that make it easier for a blood stage or Rh5 vaccine to work? In turn, if a blood stage vaccine reduces parasites in the blood, you should get less sexual gametocytes. Does that make it easier for the transmission blocking vaccine to work? And in turn, if the transmission blocking vaccine is reducing the force of infection coming into the human, does that make it easier for R21 or RTSS to work? So you may have these potential synergies around the life cycle, which I think are a really exciting area that we can now start to explore clinically in the coming years. And fingers crossed will lead to higher efficacy and better durability. So I'll just finish by acknowledging the team in Oxford. We have amazing partners all over the world, the funders, and finally you for your attention. Thank you very much.
Thanks so much, Simon, for a very informative talk. So we have 2 questions in the chat. The first question, Stephen Evans has asked, might anything be gained by having doses of new and older vaccines? I think that's one for you, Simon, or Mary.
I can start. Mary may like to add to that. I mean, I've just outlined in my talk how I hope in the future, if we do have new and approved vaccines, that we can combine with the current vaccines, that yes, we could achieve higher efficacy or more durable efficacy, or potentially explore reducing the number of doses. Given RTSS and R21 are very similar in concept and work in the same way, you may be able to use those interchangeably, but ultimately, because they're working in the same way, you wouldn't really get anything from using them at the same time. Ideally, what we'd like is vaccines that work by other mechanisms that can add other lines of defense against the parasite.
Great. Thank you. We have Andrew Farlow has said there's been much said about using AI and narrowing down drug and vaccine candidates and improving efficacy. Does anybody want to comment on that?
I'm hoping Simon wants to comment on that.
Mary, using AI at WHO, we're having some really interesting discussions about how to incorporate AI into our research at the moment. We are an immunology lab, so we're really interested in using AI to better understand how the antibodies that we make by vaccination can bind to the parasite, where they bind, how they might work, and can we predict that using AI tools. I think that's a really exciting area. What we're also discussing internally, and I don't have an answer for, is perhaps how we could bring AI into our clinical trials to advance those and what we learn from them. I think we can certainly explore that in the immunological space. I'd be very keen to hear from others or learn from others in the future how AI might be helping in terms of delivering clinical trials and understanding vaccine impact.
Thank you. Mary, I have a question for you about assuring equity and ensuring, Mary or Eliane, and ensuring that those who are most at need of getting the vaccine get it, in particular in relation to the number of doses and the fact that the vaccine dosing isn't at the same time as the routine childhood vaccinations.
I'm going to ask if Eliane would take that because she did quite a bit of work on this.
Yeah, I think at the global level, as I mentioned, the framework for allocation of limited doses has really helped, where at the global level, there was a suggestion of how to do this in an equitable way. And then I think a key difference to the COVID vaccine situation is really that virtually all countries with high malaria burden are Gavi supported. So we were able to work with Gavi. And at the time, it was a curse and a blessing to have a single manufacturer, but with that manufacturer to make sure that the limited doses really go in accordance with that framework. And then the way the Gavi model works, countries need to apply in order to get support. So in their application, they had to present that methodology. And so there was a certain level of reassurance that it would really go to these areas. And actually, that's what we're seeing now. It comes with challenges because these are often the most challenging areas to provide health services. So some of the coverage levels might not be as high as they could be if countries had started in easier to reach areas.
Thank you. Well, I think we've actually come to the end of our session, Mary. We haven't run out of time for a question for you. Apologies. I wanted to thank all of the panelists for a really fantastic talk. We've heard all about how vaccines are transforming malaria prevention globally and about some of the challenges and opportunities. I suspect this session could go on for a whole other hour, but thank you very much for agreeing to participate, and thank you for everybody for attending. We really appreciate it.